Hello, I'm delighted to be chairing this Bayer LinkedIn Live discussion today with an exciting panel of two primary care physicians. I'm going to introduce those in a minute, and two patient advocacy representatives. Now, I'm a professor of primary care at the University of Oxford, and I'm also the president of the European Primary Care Cardiovascular Society, and I'm joined today by Dr. María Cebrián, and she is practicing in Murcia in Spain and is also vice secretary of the Spanish Diabetes Federation. Another primary care physician is Petra Sandow, who is an internist based in Berlin. And those two are joined by our patient advocates, Elizabeth Dupont, who is the regional manager of the International Diabetes Federation Europe. And finally, Aditi Kandawalla, who is actually the founder of the Heart Health India Foundation. So we've got a very expert panel here to discuss actually a very important topic. And that topic is the importance of UACR testing in patients with type 2 diabetes for the early detection of chronic kidney disease. So this session is about prevention of the progression of kidney disease, but also the prevention of what is commonly associated with CKD, an increased risk of cardiovascular events. And to take us through that, we're going to have this discussion in two sections. We're going to initially focus on the relevance and importance of UACR as a test in itself, and we'll then be wanting to consider practical opportunities and barriers to how we can more successfully utilize UACR testing in primary care. Now, I also want to welcome you, the audience, to this discussion session, particularly to those of you who have joined live. And remember that you are able to post questions during this discussion using the chat function. And please do that, because it will be great for us to take some of your questions live during the discussion section of this meeting. It's worth me also reminding us that this LinkedIn session will, after the live session, be subsequently posted on the Bayer Linked Live site, and so you will be able to view it or recommend it to colleagues if you found this discussion helpful. So let's get on with the discussion, and I'm going to ask my first question from Anna, and it basically is for you to talk to us about briefly what the UACR test is, when should it be conducted, and how. So over to you, Anna.
Yes, thank you very much for the question, and I agree with your introduction that it's very important to make prevention in type 2 diabetes to prevent chronic kidney disease, and also we can prevent with chronic kidney disease the cardiovascular disease. So what is the UACR test? It's a urine albumin-to-creatinine ratio. That is a simple urine test that shows us how much albumin is leaking through the kidneys. I think I can say that it's one of the earliest markers of kidney damage, and with this test and also the EGFR, we have a complete picture about what is happening with our patients' kidney and cardiovascular risk. So it's very important to measure this. It's very important in type 2 diabetes to measure at the diagnosis, and then it depends at least once a year, but we can also measure twice, 3 times a year, or even 4 times a year. It depends on the stage of the patient. It's very important to repeat this test to confirm abnormalities, because albuminuria can fluctuate and we can measure this. We need to test alternated in 3 months' time. And We can do it with a spot urine sample, ideally in the first morning urine. It's not need the 24-hour urine collection. That is not a practical test. And in the lab, they measure albumin and also creatinine ratio. How to interpret this? Less than 30 milligrams per gram is normal. 30 to 300 milligrams per gram is moderate increased albuminuria, and more than 300 is severely increased albuminuria. We have to explain very clear to this patient, to our patient, because it's very important just to educate them how important is UACR ratio for the kidney and also for the cardiovascular protection for our patients. It's really important, and it's also important to explain them that we must avoid to take this sample with a urine infection, fever, menstruation, or even after intense exercise, because it's not the best way to do that. But the important message is that to explain patient that UACR is very important to check not only the kidney function or the kidney damage, but also the cardiovascular risk the patient have because of the kidney.
Great. So that's a very comprehensive start. So basically, you've introduced the fact there are two complementary tests that are used in the detection of CKD, the EGFR, which is a blood test, and a simple urine sample, which is the UACR, and you need to have both in order to exclude coronary kidney disease. And you've started to explain why we need that. But let me just turn to Petra and ask you to talk in more detail about how UACR is linked to early CKD detection and indeed prevention of cardiovascular disease.
Thank you, Richard, for your question. I try to answer now. The problem is that CKD, we know it from our daily work, is a very silent disease. That means that normally we detect our patients much too late. We detect the kidney dysfunction when the kidneys are damaged, and not only too late for the kidney function, but if we don't detect it early, we have also problem with the detection of cardiovascular complications. We know that there is a very well-established link between kidney and cardiovascular health. That means when one is under the strain, it will also impact the other one. The main risk patient is the patient with type 2 diabetes and CKD. I think it's a horrible number when we say that a type 2 patient with CKD has a 4 times higher risk for cardiovascular events than patients who don't have one of these problems. 4 times, I think it's a very, very high number. That means for us in our practices that it's very urgent to test not only routinely HbA1c in our diabetes patients and also EGFR in our diabetes patients. We must routinely test also the UACR to detect the kidney dysfunction very early, to start treatment earlier, and also to prevent earlier from cardiovascular complications.
Very good. So again, we've reinforced the need to do both tests, and I mean, in this instance, really, you could summarize that the EGFR is an estimate of the functioning of the kidney, and the UACR is a proxy for kidney damage.
That's
so
it.
You're measuring two different parameters in relation to CKD by using both tests, and you've identified a really very high increased risk of CKD when they coexist. So obviously, you're explaining why we as physicians should be taking UACR more actively, or considering it as a condition more actively. But in the end, the most important recipient of this information are patients. And I'm going to ask you, Elizabeth, if you could talk to us about experiences patients, diabetes patients, have shared with you in relation to these issues.
Thank you, Richard, and thanks, Anna and Petra, for the very clear explanation. I think this is really what people living with diabetes would need from the healthcare professional. Unfortunately, what we hear from them is that very often they are not aware of at least not enough aware of the risk of developing chronic kidney disease, not talking about the cardiovascular risks. I believe this is very much linked to what you also said, Petra, is that, first of all, when they see the healthcare professional, what the focus of the conversation is about HbA1c. So it's very much about the glucose control. And there is very little time to speak about, the other risks. And I also heard a lot from them is that when, you go beyond the HbA1c, very often what they remember from the conversation is more the problem of diabetic retinopathy because they're afraid of becoming blind, or the risk of amputation, because that seems an immediate impact on their quality of life. And this is very visible. You spoke about, the silent nature of CKD. And so even if this is mentioned, they see that very much as a distant future. So this is not necessarily something that they would prioritize in terms of, their care and the prevention that they can have around that. So just to add to that, what we very often hear is, I wish I had known earlier. So it's very much when, as you were saying, the damage is already done, that they realize that they could have even prevented it or at least slowed the progression. So I think this is something which is critically important to remember.
Oh, thank you, Elizabeth. I mean, that's a really good reminder to us that patients sometimes actually express regret that things that they're at risk of weren't known to them beforehand. Although obviously sometimes it has been discussed with patients, but there's a lot of information given to patients and they're prioritizing, you stress this, the things that seem to have most immediacy for the patient. And with conditions that are essentially silent and potentially medium to long term, us repeating messages is very important. Don't assume that because you said something once that it will have been taken on board. So very important messages there.
Yeah, and if I may add something here, also it very much depends on the time where the message is communicated. Yep. When it's a diagnosis, they have the shock, the anxiety. They cannot hear about the complication. So I think this is also something very much to remember.
That's good as well. So you might initiate all the investigations to start with, because they're important at staging your patient, but you may reserve significant discussion about them to follow-up visits rather than doing everything at the same time. Well, I think you're talking about some really practical considerations that we need as doctors during the consultation, but we also know that there are significant barriers to testing taking place in the first place. And Aditi, let's ask you about what are the sorts of potential barriers to testing.
Thank you, Richard, for this question. And first of all, I think how Elizabeth and Petra have already talked about the word delay. So, and they have emphasized on this particular word. So yes, there is a lot of delay that happens when the UACR testing, especially in the Indian domain that I can talk about. The tests are done in the tier 2 and tier 3 towns, and the lab results go. And the turnaround time, sometimes it's really too much. So yes, that is one of the barriers. And again, if you have to talk, there are a lot of budget limitations. There are out-of-pocket expenses, which the patients and the patient families have to see. And because these are not covered under the government schemes as of now in India. And yes, there are also a lot of cultural stigmas that are seen because it's a urine test. And we really have to think about how this particular information is communicated to the family and what could be done about it. There could be So these are the perspectives from the patients and the family side. Of course, then there are doctors, the clinicians. If they are informed about it, whether they are actually following the current guidelines, the global guidelines, there is a lot of mismatch that happens here in the Indian territory. So multi-stakeholder relationship and coherence is definitely needed in this particular space, wherein all of the systems can work together in benefit of the patients, right?
Yeah, that's very interesting. I mean, you brought some sort of international dimension there. I mean, I think this issue about reimbursement we might well not think about in some systems, but obviously is quite important to others. And of course, the ultimate financial costs associated with CKD and the events, cardiovascular events that may be linked to it, are huge, both for patients and for health systems. So more recognition of these issues is clearly needed. So that's very interesting. I mean, does anybody have any additional points they want to make of this section? We're talking about the importance of the test and what it means to both doctors and patients. I think
if I can, I want to say also that we are talking about spread the message and explain very well the patient, the burden of the both tests, UACR and also EGFR. But I want also to say that it's also important to spread the message between professionals, because UACR is a missing value that we are not testing enough, because it's an important value to address cardiovascular and kidney health, but it's also important to measure it. If we don't measure it, we cannot know what is happening.
Yeah, very important point. That this, I mean, we do silo ourselves a bit sometimes, and we may assume that another clinician, particularly for a patient with diabetes who might be seeing 2 or 3 different types of practitioner, we may assume that somebody else has dealt with the topic, and we really cannot afford to abrogate those responsibilities. And we can't assume that what I would think, which is that doing a urine test is much more preferable to having a blood test. There will be patients who think quite the opposite. So we can't assume that what we think is what is the case, and we should therefore take an assumption of responsibility to discuss these things into our own hands. And actually that nicely and obviously deliberately leads me into our second section of this discussion, which is about things that might work that will improve the situation. And I'm going to ask you, Petra, to kick off with what can primary care physicians do to increase UACR testing?
What can we do? We can do a lot, I think, but the first thing is that something must be done for the physicians, because education is the main topic, I think. We discussed it in our first session. A lot of my colleagues have the opinion that you need the 24-hour urine to be brought in the practice. It's a problematic test, and so it must explain that it's easy. Spot urine is good enough. And also, I think education in the KDIGO guidelines. It's not common. I work in Germany. The KDIGO guidelines in GPs, I don't think that these both work very good together. We also need education for other healthcare professionals, not only in GPs, because not all our patients are only our patients. So we must have also the specialists in our community to be informed. And also, I think Elizabeth and also Editi told it, patients also must be educated, that they come to the practices and say, I have a problem, I think I have a problem, I have a family history or whatever. I think it's also necessary that the UACR is included in our routine panels in our practices. We have routine panels for patients with cholesterol, and in our diabetes patients in the moment, there's only the HbA1c, the LDL, and also the EGFR. So UACR must be part of these routine panels, and not only we don't only need to have the value, it's when we have the diagnosis, it must be clear that we have a follow-up with our patients. And it's not only a value in our IT system. So I think it's necessary to ensure the patients follow up very promptly after having the results, to start very promptly efficacious treatment. And the last point I will mention now is that I think it's very helpful to discuss with an IT company that we have the possibility of electronic alerts. I have to do the UACR once yearly in diabetes patients, also in patients with hypertension or patients with family history. And when I don't do it, an electronic alert must pop up. I think when we have these points, it will be much easier for us to think about the UACR test and to discuss it also with our patients.
Okay, well, lots of practical suggestions there. I mean, I liked you illustrating actually that we've been focusing on practitioner knowledge and understanding, patient knowledge and understanding, but actually there needs to be much better recognition of the priority of UACR by health systems themselves, and that it needs to be basically incorporated into our clinical pathways as a matter of routine. But that doesn't get away from the educational messaging that's needed now, both amongst the practitioner groups and patient groups. And that's a nice segue for me to now ask Anna if she can give us some hints about better communication of the importance of UACR testing with patients.
Yes, I'm always saying that me as or us as primary care physicians, we are very close to the patients and we play a crucial role in educate our patient. And we can explain very well what is UACR, and we have the capability to make the patient understand the message. I have 3 tips that are basically use simple words. We must not say albuminuria or microalbuminuria or macroalbuminuria. We must say, Manuel, John, Maria, that is, please collect the urine, bring me the urine, because the urine is very important to check your cardiovascular risk, and also is for prevention. The second tip I want to share with you is that we must explain to the patient that is part of the regular check. As we say, Maria, Pepe, or Antonio, every year we have to check your A1C levels, your blood sugar levels, your cholesterol, your blood pressure. It's also important to measure your UACR. And for me, it's really grateful when a patient comes to my clinic and ask me for the bottle for collection the urine, because they say, doctor, you told me that it's important to check my cardiovascular risk. And third of all, I think it's very important also to align expectation and connect with patients care about. It's very important we're professional and patient, we are in the same page, and it's really important just to explain them that this is for prevention. It's not about scare patient with the complication and all that. That is for prevention, for prevent heart attack, for prevent dialysis, and for prevent type 2 diabetes complication. I think with these simple rules, patient can understand very well what is the burden, what is the importance of the UACR testing.
Excellent, excellent. So again, some practical tips about how we can more routinely introduce the concept of UACR into our communication strategies with patients and link why we're doing it to outcomes that mean something for patients. So I think we're going to finally ask the experts here in what patients think, because you spend a lot of time talking and listening to patients. So let's just turn to Aditi and Elizabeth here about what you think are potentially more effective communication or education strategies with patients. Aditi, do you want to kick off?
Yeah, I think with patients and their families, the first thing that really helps is to tell them that, okay, this has been one of the things that we have talked to and done with the other patients. So there is an empathy, first of all, that is seen. And yes, at some points for the repeat test, as Petra mentioned, and that it has to be done in 6 months time period and so on and so forth, so that you don't miss it. So that kind of system has to be driven definitely by the HCP side. So their training is also needed at times. So there is a very closed kind of knitted environment which is required with the patient families and the HCPs. And I think patient advocacy groups really play a very important role here to show that, okay, yes, this is the kind of condition and it will help you prevent cardiovascular risks as well. So this is important. So I think the more we talk to patients, it really helps.
And Elizabeth?
Yeah, if I may add to what Aditi mentioned, and I fully agree with you, but I also really like the way Petra started with education. And I like the fact that you start with the education of the healthcare professional, which is definitely very important, but Aditi, you didn't forget the education of the people living with diabetes, which, as Anna was also mentioning, is very important for them to understand the severity of, chronic kidney condition and the risk when this is being developed, and the cardiovascular risk. So I think in terms of education, there is a lot to be done, and when we speak about education, it's also very much about patient empowerment. It's really giving them the information and the tools to ask the right questions and to have a proper discussion with the healthcare professional. Because yes, in the ideal world, all the healthcare professional would come up and say, this is what you would need to do, and there would be the implementation of the guidelines, etc. But we also know that it's not always the case, and there are many reasons for that. So if the person himself or herself is able to raise the question and say, maybe I should be tested, and I should, have a follow-up to my previous test, etc. I think that this would be critically important. And as Aditi was mentioning, this is also the role of the patient associations, to make sure that we provide people living with diabetes with the right information. But to provide the right information, this has to be co-created and co-developed with them, so that we know that it's a language that they feel comfortable with. I'm always a little bit, I don't know how you say that in English, but put aside when I hear UACR, EGFR. To me, these are acronyms that are very difficult to grasp and to remember. So having plain language, I think Anna or Petra, you mentioned that also, the importance of having simple, clear language that really delivers the message that needs to be delivered. And I think also what we heard, because we discussed some of the educational material that was developed, to raise awareness about the risk of developing CKD. And then the answer that we got from the patients were, but what are we supposed to do with that? So they had the information, but they didn't know how to activate the information. And so that's where, when you discuss that with them and co-create the document, then you can end up with, some practical information. As you were saying, Anna, the tips that you were having for healthcare professionals. What are the tips that could be given to people living with diabetes so that they are prepared for the conversation with the healthcare professional? And I would add something which is probably very important to Aditi too, is the fact that this language and this information needs to be in the national language, because it's very difficult for people to get, to the full understanding of what it is in another language, and the cultural aspect also needs to be very much taken into consideration in these material.
Well, I think those are points all extremely well made. I mean, the reality is that physicians use acronyms and abbreviations all the time. We have to, because we're talking about a lot of technical terms. But even physicians sometimes will struggle with what UACR is, which is why we have actually spelt it out in this session, is that, to be honest, you can't assume that even physicians will be aware of what it means. So it's a very important lesson for us there. I mean, just thinking about that, are there alternative terms that you could use? Like, for example, it's a urine test to check kidney health or something like that. Is that the sort of terminology that we think we should be using?
I think that would be very culturally important to understand whether it works or not. I know that we were discussing with UK people and they said, yes, why don't you simply call it a urine test? So for them, that was, the most obvious choice, but I'm not sure Aditi would agree.
And I get what you are trying to say here, but I think there are obviously cultural stigmas related to it. But as I mentioned in my previous phase of talking as well, that when I'm saying to the patient that, okay, this kind of thing has happened with the other person, and the case study, those stories are there with them, it really helps. And then that urine test is just a kind of a routine thing that they think that, okay, this is a life-saving thing for me as well. So the more the relatable terms are there, the more relatable stories are there, people will say yes.
So that's a good point. I mean, I think we've repeatedly been saying during this session, because we've sort of finished the discussion now and we're about to go into questions. So I'll just remind those of you who are listening in live to this session that now's a good time to post your questions. I've got a couple already that I'm going to pose to the panel in a second. But I think there's been quite a lot of messages that I've taken on board already in this discussion section, because I've heard about the importance of doing UACR testing alongside EGFR testing to determine CKD function in patients with diabetes. I've learned that I cannot use these acronyms with patients because I've got to translate them into something more meaningful, and I need to think and talk with people, particularly patient representative groups, about how I might articulate why I'm doing these tests that are trying to detect risk of something or the presence of early disease. So I think these are really important factors. We've heard that UACR is a simple urine test. It's a single test. It's not a 24-hour sample. It can be done at any stage. It's not a large volume, and that's all very important. We've heard that it can detect early disease, and the reason for that is that you can then do management strategies that reduce progression. And we've heard of this very accelerated risk of cardiovascular disease. And let's remember that cardiovascular disease events remain the world's most important cause of disability in the populations and premature death. So preventing cardiovascular events is a very important strategy for all health systems. And we've also spent quite a lot of time talking about how it should be a more systematic approach to assessment of kidney function in our patients, and that health systems need to take part of that, as well as practitioners, as well as the way we communicate risk with our patients. So have I missed any points, panelists? Do you think there are any other points that have been made that I should have prioritized before we get into the questions?
It's a very good abstract. I cannot do it better. I think you have all the points there.
Good. Well, I'm sure some of our listeners might point out that I've missed a great important factor, but I'll wait and see if they post that in the chat function. But whilst
Richard, I'm so sorry. I'm just adding one more point here that definitely there are a lot of resources that we tend to prepare even for the patients, families, doctors, so on and so forth. I think one very important point, which I think has been missed, is how we think about the strategies to disseminate that particular information throughout. Because in India, it's a huge country. from tier 2 towns to tier 3, and the samples go to Mumbai, Delhi sometimes. So yes, all these kind of dissemination strategies are also needed so that it reaches the right audience, the right doctors, and the patients as well.
Yeah, and this point that we have to repeat messages. We cannot rely that something spoken on one occasion is going to be recalled on another occasion. And let's face it, we can't just speak to these issues. We should be providing support materials for patients or advising them where they can get extra advice. And it may be from patient advocacy groups, or it may be from a medical site. But we should have these materials available to us so that we can improve the potential for patients to manage their own problems. And actually, that feeds into one of the questions that I had, which is how could understanding their UACR results empower patients to take a more active role in their kidney and overall health management? I'm going to ask you, Elizabeth, if you could respond to that question.
Yes, thank you very much for the question. And I think, as Petra and Anna already said, it's the importance of getting the results promptly, but also that there is a prompt follow-up with the healthcare professional on, what it means. I think for the person living with type 2 diabetes, understanding, the level of the damage to their kidney is critically important, because then it makes it visual for them. It's no longer something silent. It's something that is there. And that's how they can then start thinking about, what can I do to prevent the progression? What can I do to make sure, that the situation doesn't worsen? So it's really helping them to activate the information that they have received and to put it into practice. So this is critically important, and this prompt follow-up, because I think for people living with any type of condition, it's the waiting time that makes you lose the momentum and the willingness to act and do something.
Yeah, so I think this better understanding is, as you say, critical, really. I mean, I think that if patients want to get more actively involved in their healthcare, and that's in the interest, obviously, of practitioners and health systems, that patients are more actively involved in the management of their own health issues, then that isn't going to happen unless they're equipped to understand what they do with that information. And the more effort you put into that, and the more the patient actually does prompt you when they do things or does things that involve healthier kidneys and healthier lifestyles, that's obviously to our advantage as practitioners as well as to patients themselves. So I've got another question which I think is quite interesting, because it relates to progression, because we talked about if we diagnose CKD early, we might be able to reduce the progression of disease. How can UACR testing help patients who might be rapid progressors of kidney disease? And do you think that's going to affect more personalised patient care? I'm going to ask you, Anna, if you can respond to that, but anybody can chip in if they want to afterwards as well. But Anna, you kick us off.
Okay, yeah, I think UACR is an important tool, and it can give us the photo, the movement photo, what is happening in those patients with UACR more than 300 or with a quick increase of UACR. Is really important to have this in mind, because for this patient we are going to use personalized care, and also we are going to prescribe things that can improve and can decrease this risk, because we can now reduce the albuminuria with some drugs. We are also make an important job with this patient, because we are going to be more strict, maybe with A1C levels, with glucose levels, maybe with cholesterol levels, and prescribe statins, also blood pressure. And I think it's really, really important just to keep this in mind, and also increase monitoring is those in this patient with a rapid UACR increasing, or also at that stage is not enough with once a year. Maybe we have to check and recheck these values every 3 or 6 months, and maybe we are keeping in mind just to consult to our colleagues, to the nephrologists, if there is something they can also do for the patients.
I think this is very good what you said now, Anna, because the next control appointment we can discuss with the patient when we have a lot of different values, and we can treat today CKD.
Mm-hmm.
I work as a GP since more than 35 years now, and I think you nearly the same. And we have a lot of time, we can't do anything. And so the value is necessary, academically necessary, but not for our daily practice. But now we can treat, we are able to treat patients with CKD. And so we must look how rapidly the kidney function decreases to think, do we start with just one drug? Do we use 2 from the beginning? What can we do for our patient? What is necessary? And I think when we have a 95-year-old patient with a little bit eGFR decrease and a little bit microalbuminuria, we won't do anything. So we must look for the patient, and we must look in which time the value decreases. And so this is the reason to decide what to do, when and what to treat.
Okay, Petra,
Yes.
do you want? Anna, do you want a quick response to Petra? Because I've got
Yes,
another
I want
question
to
for
add.
you on this.
Sorry, yes, I want to add one sentence, one word, because we can now translate it in a positive message.
Yeah.
We are always saying the patient that is for prevent, but we can modify this for you. So we can translate this in a positive way.
And I think this important message that we should be personalizing information a bit more for patients who are in different stages of their lives and have different priorities for their healthcare needs. There is a good question here from a GP in the audience. How can patients support kidney function through their diet and hydration? So actually, Petra, since you've been at it for 35 years, what's your answer to that one?
Sorry, I couldn't understand you. Can you please repeat it?
So it says, how can patients support their kidney function through their diet and hydration?
I know that sodium is no good idea for these patients. We also know that drinking too less. A lot of years we told patients with renal damage, please only just 1 liter of fluid every day. Today we know it's not necessary to discuss it. It's so extremely. They can also drink about 2 liters like others, but sodium, I think, is the biggest problem. And sodium not only put on the eggs, but also sodium in fast food. There is a lot of it, and so we say, Mediterranean costs the best you can do without putting the salt on top.
Yeah, so I think that is an important message, and obviously it's important for high blood pressure as well. And if patients need to add salt, they can just substitute it with a potassium salt as a sodium substitute. And I think this point about not restricting fluids, but thinking about the calorific content of the fluids and generally becoming more aware of the content and calorie associated with processed foods that we eat. Now, we only got a minute left of our sessions. I can't believe we've actually used up most of our time. But is there any final point that the panelists feel they want to make? If
maybe
not,
I'm happy to react on what was just said about the importance of personalizing the care and the treatment and turning it into a positive message. I think that's critically important.
well,
Thank
I think
you
that's
for
a
sharing that.
perfect point to end on, positive messaging. And I'd like to say thank you all for contributing to a very interesting discussion. Thank you.
Thank you very much.
Thank you, Richard.
Pleasure.